So over the next 20 minutes, I'll be talking about the new role of cardiologist in diabetes management. This is going to be my agenda. Going to be talk about the past, some basic, very brief review of the type 2 diabetes mellitus with the cardiovascular disease. Then we're going to shift the gears to give you a bit of a summary of the state of diabetes treatments before 2015. And then we're going to talk about the present, which is the new cardiovascular outcomes in type 2 diabetes mellitus. And you're going to see that it's primarily about heart failure. So basically, we know that in patients with type 2 diabetes mellitus, the cardiovascular disease prevalence is high in those individuals. But for some reason, heart failure seems to be the most common presentation as compared to MI and stroke. Actually, if you look at patients with type 2 diabetes mellitus, once they develop heart failure, their mortality rate over 5 years plummets down significantly. It's almost, you're talking about 75 compared to 25% 5-year mortality. So per se, that basically gives you a significant message. This is a beautiful slide which reminds us of the MI with the type 2 diabetes mellitus and no diabetes mellitus. So basically what I want you to look here is there. So if you have a patient who has HFrEF, heart failure with reduced ejection fraction, with no type 2 diabetes mellitus, this patient's cumulative incidence of cardiovascular death and heart failure or heart failure hospitalization is similar to a diabetic patient with HFpEF, which means if you are diabetic and you developed heart failure with a preserved ejection fraction, your mortality is similar to somebody who has no diabetes and has reduced ejection fraction. So that's another significant value. And that's basically a picture worth of 1,000 words. So those are two patients. The one on the right side is having basically hypertension with LVH. Obviously, both of them have died. Otherwise, I would not have projected the pictures for you today. So this patient is probably our diabetic patient who has HFpEF. Though that the other patient has dilated cardiomyopathy, probably because of MI, because he has a scar. So those patients died. So that's the message that I want to give to you. If you have diabetes, that's very bad for you once you develop that. And because of that, the basically American Diabetes Association, American College of Cardiology, as of 2022, they've made those changes. Among those patients with diabetes, routine assessment for symptoms and control of risk factor is crucial. Measurement of a natriuretic peptide or high sensitivity troponin at least yearly is recommended in stages A-B. In those with abnormal biomarkers, you should go with this basically imaging. And that's based on what I have to mention to you with regard to the epidemiology. Now, this slide is going to repeat itself again and again and again. This is from Massachusetts Hospital. And basically, it shows you the multiple defects contributing to the pathophysiology of type 2 diabetes mellitus necessitating targeted therapy. You have basically the different pathophysiologic mechanisms at the level of the islet B cell, alpha cells, increased glucose hepatic production, neurotransmitters, decreased glucose uptake, increased glucose reabsorption in the kidneys. And those are basically the different molecules that we have available to us. So it's important that you understand the different molecules, and I'm going to be talking about the evidence-based for each single group of those, albeit very briefly. So we're going to talk about the past. That's the past, I mean, before the era of 2015. So we're going to start with the insulin, sulfonylurea, and metformin. Insulin, of course, you know the evidence for it was basically non-existent. So I'm going to go now with metformin. This is a pooled adjusted risk ratios for metformin compared with placebo for all-cause mortality. And very clearly, you're going to see that basically metformin overall was decreasing mortality by about 20% here. The second molecule is sulfonylurea. This is a meta-analysis, and basically this meta-analysis showed us that there is no consistent association of the use of sulfonylurea with regard to cardiovascular MACE. That's why they are coming out of favor in the cardiology literature. Now we're going to go to our controversial TZD molecule. Those are the areas that they have been. Now remember in 27, two separate meta-analyses came and they gave two contrasting signals. The first one was the rosiglitazone meta-analysis, which basically showed that there was a significant increase of MI with a significant p-value, and there was a trend towards cardiovascular death. However, when it came to the pioglitazone, there was, if you'd like to say, a trend towards less MI, but the p-value was not significant. The reason that those molecules again came out of favor for the cardiology community is that there was an increased risk of heart failure with both pioglitazone and rosiglitazone, and that's why we started not liking this group of medications. Now I'm going to shift the gears to the DPP4I inhibitors, and those are basically the four major trials. We have the SAVOR, which is the saxagliptin, Examine alogliptin, TECOS sitagliptin, Carmelina is our linagliptin. If you look at the 3P MACE for those four molecules, they have been quite neutral with regard to the basically 3P MACE. When it comes to heart failure hospitalization, again, they were neutral except for one molecule, which was basically here the saxagliptin. There was a trend towards more heart failure hospitalization, but the p-value was not significant. Now we're gonna talk about nowadays, which is what we are doing, the molecule which we're going to be talking about. So there are two groups of molecules. The first group is the GLP-1RA agonist molecules. I'm going to take you through the trials as basically a summary. So it's important for you to understand that, especially the cardiologists. So you have basically one molecule which was studied post-ACS patients. It was primarily post-acute coronary syndrome patients. The rest of the molecules were talking about patients with or without atherosclerotic cardiovascular disease. The only study which looked as a primary prevention primarily was the dulaglutide, which was basically the rewind. 31% of the population of that study had atherosclerotic cardiovascular disease, which means that 70% were primary prevention. They did not have overt atherosclerotic cardiovascular disease. So that's the overall picture. So let me take you to the lixisenatide first, the ELEXA. In the ELEXA trial, they looked at basically the primary endpoint. It was a neutral. So post-ACS patients, if you use the GLP-RA agonist, it is neutral with regard to the cardiac outputs. And those are the different basically outputs that it looked at. So definitely there was no significant difference with regard to the cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for unstable angina. Now we're going to take you to the non-ACS GLP-RA cardiac vascular outcome trials. Those are the LEADER, SUSTAIN-6, XL, HARMONY outcomes. I left REWIND alone because I said it's the primarily primary prevention trial. What you're going to notice here is that the LEADER was the mother study. It was basically almost the same as the IMPA in the SGL2 groups. So what we are finding here, so there was a clear advantage in the liraglutide for the triple MACE with regard to non-inferiority and superiority. So in this study, they looked at the molecule as non-inferior as well as it was superior to placebo. What about SUSTAIN? Again, this is the primary outcome of the triple MACE. The same finding was there. There was a basically 26% reduction in the combined triple MACE in favor of the semaglutide. And this is our REWIND. We said REWIND is peculiar because again, you have to understand that 70% of the population of the REWIND were primary prevention. It's important to know that. Because if you're gonna come with a patient who has no overt atherosclerotic cardiovascular disease, as an evidence, as a clinician, if you're gonna use any GLIRA agonist molecule, you probably should use this because it has the best evidence in that group. And that's what we need to understand. It's important for us. So again, there was a 12% significant reduction in the composite cardiovascular outcome, non-fatal MI, non-fatal stroke, and cardiovascular death. And this is the summary of the GLPRA cardiovascular outcome results. So there was an overall 15% relative risk reduction in MACE. When it comes to heart failure hospitalization, you're gonna see that liraglutide is coming up there, exenatide and albiglutide. So those are the different features. Those are the proposed mode of action of the GLPRA agonists. They somehow reduce blood pressure, weight loss, improved renal outcome. Weight loss, I'm going to show you the specific molecule, which probably our diabetology colleagues know about. Improved vascular compliance, lowers glucose, and less hypoglycemia. This is basically the weight loss effect of GLPRA. Here, it's of course the clear example is the semaglutide. Semaglutide decreased weight in patients by about 15% with an average of 15 kilogram weight loss over a follow-up of 68 weeks compared to placebo. And that's why we like it. Now I'm going to shift the gears to the final molecule, which is our SGLT2 inhibitors. This is one of the best slides that I usually teach for my, again, postgrad students. Is the same thing. Heart failure, atrial fibrillation, acute coronary syndrome, whenever you have an incident, you're probably gonna start a domino effect. So you're gonna have an incident of heart failure. That's gonna push you later on to develop another episode and another episode. And whenever you have a recurrent episode, your mortality probably is gonna go up, and that's gonna end up into death. That is why, if you're gonna look in the clinical trials, when they choose heart failure hospitalization, it's a significant surrogate because of that. So that's how we link the clinical knowledge to our basic knowledge. Now, if you remember that back in 2019, the first steps of the new legacy came, which is with regards to the SGLT2 inhibitors, because by 2019, SGLT2 is projected in the guidelines. And I'm going to take you very quickly through that. So the first trial which came was the Emperor Reduce. This was basically patients who had reduced ejection fraction. 50% of this population were without diabetes, 50% with diabetes, 48% had chronic kidney disease. And there was basically a 25% reduction in the primary endpoint. Then came DAPA heart failure in 2019. And again, it showed the same thing, 26% reduction in the primary composite outcome, cardiovascular death, heart failure hospitalization, urgent heart failure visit. Again, heart failure hospitalization. This is Professor Zanad's meta-analysis, which is very known to everybody here, and it shows us the combined pooled of the DAPA heart failure and Emperor Reduced trials. And again, what you're going to notice is that there was a 13% reduction in the all-cause death and a combined 14% of the cardiovascular death. This is Soloist heart failure trial, which is again, Soloist was peculiar because all of the patients were diabetes, unlike the other two trials. There were percentages of patients having diabetes. Soloist was primarily patients with type 2 diabetes mellitus. That's why you see the basically heart failure hospitalization was significantly seen here. And if you're going to notice that in those trials, the separation of the curves is really very early. When it comes to, for example, MPEREG, basically the significance touches 28 days. So by 28 days, you have gained a significant reduction in heart failure hospitalization. And by 2021, the legacy of SGLT2 inhibitors have been really stamped down by the guidelines. By that time, we have the Emperor Preserved study. This is the basically the randomization flow of the study. Now, remember, they used ejection fraction above 40. From the previous studies, we were looking at patients with reduced ejection fraction. So this is the study that looked at patients with preserved ejection fraction. Of note, 2/3 of the patients in the Emperor preserved had an ejection fraction of about 50%. And those were the main results of the trial. So there was a demonstrated, basically a clinically meaningful 21% relative risk reduction in the composite primary endpoint of cardiovascular death or heart failure hospitalization with a very small NNT at 31. And if you look at basically our friend first and recurrent heart failure hospitalization, that was reduced by about 27% in favor of the basically molecule in patients with preserved ejection fraction. And hand by hand came the DELIVER trial, which again, it constituted a better, if you'd like to say, patient population. It had everything almost in it. And the mean LV ejection fraction was 54%. And what they have found is the following: patients with heart failure, so the mean ejection fraction was 54%. The ejection fraction distribution was in this manner. So less than 34, a third; 50 to 59, a third; and more than 60%, a third. And the NYHA classification, patients were primarily NYHA 2, and 25% were NYHA class 3. And again, there was an 18% relative risk reduction in the composite endpoint, which was cardiovascular death, heart failure hospitalization, and urgent heart failure visit. Those are the components of the primary endpoints. And you're going to notice that heart failure hospitalization is probably the main player here in the basically event. Those are the potential mechanisms. So I'm going to talk about that. I need a full lecture actually. Protection of the kidney and the sodium H co-transporter. If you're going to read anything, read about the sodium hydrogen co-transporter. It's a hot topic. And a lot of the talk that we are seeing is that the cardiorenal protection is probably, we don't know yet, probably related to the sodium hydrogen co-transporter. And because of that, this is what happens obviously in the guidelines. So now it's easy for us to understand why the guidelines state what they say. The reason that we said 2021, that was basically the stamping of the legacy. This is the 2021 guidelines, and you're going to see dapagliflozin and EMPA there as class 1 indication in patients with HFrEF. And the conclusions of my talk: the care of the patient with type 2 diabetes mellitus and cardiovascular disease requires collaborative management between the PCP, endocrinologist, cardiologist. Non-endocrinologists like us should no longer sit on the sidelines with respect to choice of drug for treating type 2 diabetes mellitus. For patients with type 2 diabetes mellitus and CV disease, addition of SGL2, GLP-RA is recommended even ahead of metformin. The treatment of the patient with heart failure, even without diabetes, now we are talking about SGL2 and plus minus GLP-RA receptors. And you need to get to know these therapies. You will be recommending and prescribing them sooner than later. Thank you very much.